I'm Jim Mold. And today it's my pleasure to be talking with Lee Jennings, who's a general internist, an overworked geriatrician. She's associate professor and director of the section of geriatric medicine in the Department of Internal Medicine at the University of Oklahoma Health Sciences Center. Um, we know each other, but haven't spent a lot of time. And I'd like to hear again your version of how you learned about goal-oriented healthcare.
Oh, sure. So I was a eager geriatric fellow, interested in starting a career in health services research, and I had the opportunity to pilot goal attainment scaling and in a dementia care specialty clinic. And so we had a CMMI grant at that time where we were piloting a new clinical program, and we integrated asking individuals living with cognitive impairment and also their caregivers, depending on the level of cognitive impairment they had, about sort of what their goals were. We did some qualitative work, and then we translated that into a study looking at what people's goals were and if they attained their goals as a result of that new care program.
And did they?
About 2/3 attain the goals, and one of the things that we learned was that asking one time about a goal is not enough. That goals do evolve, and I think people's values and preferences and um, larger goals really have more consistency. But what's important to people to attain in the near term and how they're going to do it, and those smaller objective things do change over time. And there was a lot of value in asking people what was important to them and understanding also what they were willing and not willing to do to attain that, or how they defined that outcome. And that you could really model the care that you delivered around helping people meet what was important to them. And that was really, I think, paradigm changing for me as a clinician and as a researcher.
And it sounds like it's an ongoing discussion. It's not a one-time goal setting process. It's an ongoing discussion focused on
I
what
think it,
people, yeah.
yeah, I think it really is. I think that's right. I think that understanding what's important to people, but then what are we is what we're doing now going to help you meet that goal? You told me that this was important to you. We're at a potential trade-off here between this or that choice or intervention or recommendation. And I feel like you can guide people better, and you can if you understand, what's important to them. It
Yeah.
really, I think, is because I think there's inevitably trade-offs, right? And so it really gives an overarching across conditions framework for how you think about delivering care.
And you were working with David Rubin at
Yeah, so
UCLA,
Dave
right?
was,
During your fellowship. And David was famously one of the co-authors of one of the papers in the New England Journal on goal-oriented healthcare. So I know he had a broad view that he didn't think was just applicable to dementia or to that particular project, but he was trying to change the way we think about healthcare in general.
yeah, I agree with that. I think it really has a lot of applications for geriatrics, for primary care, and it really, I'm a geriatrician, so I think a lot about older adults, but it really has applications across the lifespan, right? Because many people of all ages live with chronic conditions, or they may have injuries, or they may have changes in health states. And so, thinking about um, what is important to them matters, or it may be motivational, right? So you think about, how do you help people make behavior change to improve their long-term health? Or how do you think about prevention? Or how do you motivate people to do their colonoscopy? And so I think tying it to what's important to individuals and helping them realize that these are things that may help you, maintain health states or achieve health states or prevent outcomes that you don't want, I think is a valuable way to help people be invested in their own care and communicate about why we're recommending what we're recommending.
So when you first learned about it and you started using it in your study, um, did you see it as a paradigm shift?
I did. I mean, I think when we train in medical school, we train about diseases. So we say, okay, for this disease, you do this, or you ask about this, or these are the available treatment options, right? It's very focused on that. Or there's a checklist for prevention. You need to do all of these things if you're at this age. And I think the paradigm shift was realizing an incredible burden you potentially put on people if you have this giant checklist of things that they are being asked to do, or you're recommending one thing for one condition and something that's contradicts that for another condition, and how confusing that is. And so when I began to think about when we ask people what matters most to them and we direct their care toward that, and we direct our recommendations toward that, it helps clarify some of that, even when we maybe don't have, even if we don't, and discussions around when we don't have super clear evidence, right? Like I know, that I think is another way to help frame that. So I found it to be very helpful.
So, how successful have you been at integrating this into your own practice?
So I will say I fairly routinely ask people about what's important to them with their healthcare, with their mobility, with cognition, with their daily life meaningful activities. And what I don't do regularly is the goal attainment scaling. I find that to be a much more useful tool for research, for my research studies, when we're actually trying to measure sort of an individualized outcome across a cohort. So we'll use that more in the research, but I do think asking people about their goals, and then how do you feel like do you feel like this is going to help you meet that goal, or how are you doing with that goal? And I would find I use it most when I'm trying to help people motivate for behavior change. So I have a very quick example. I have a patient who was having knee OA and having metabolic syndrome, and had some new hepatic steatosis, and really wanted to focus on increasing exercise. And he really loved John Philip Sousa marches. And so we set but his overarching goal was to improve his health and exercise and physical activity. And so we set a small goal around listening to John Philip Sousa march every day and spending that period of time listening to that, being very, very physically active with cardiovascular exercise. And he did it, and he actually lost 20 pounds over a series of about 4 months.
Without
And I made some other changes too, but that's just an example, because that was motivating to him. And I never would have understood that if I hadn't asked, why do you want to do this? How do you think it would work for you? I would never would have prescribed listening to John Philip Sousa, but that is what worked for him. It was actually kind of a bonding moment for us. It was something fun to ask him about. It gave a lot of joy to practice too. I think that's another really important piece to goal-directed care, is it connects you to your patients in a way that we all aspired to in our training, but sometimes can get lost in the stress of primary care.
Is it difficult for some patients to think this way? Have we
I
uh, trained this out of people?
I think we have trained it out of people. So sort of like, why did you come to the visit? Like, is what we ask. And maybe that's not the way to ask that. So I think it's getting back to conversation and sort of humanism in medicine. I think this really brings it back. I think a lot of physicians do this implicitly, right? And so part of it is thinking about how you do it explicitly. What are the questions you might ask? You actually have some great work on some of those 5 questions about what's important to you. I think giving physicians those tools are really, really valuable, and encouraging people to use them. I think you get a lot more out of that than just asking people why they came today.
Do you think it takes more time to do this?
I actually don't think it takes that much more time. I think it might take a little more time as you're getting used to framing things in a different way, but I actually think it cuts out stuff that's not relevant in a way, and allows you to focus what's on what really is relevant. And you have to remember, your patients can only take away so much from one visit anyway, right? And so why wouldn't you focus on what's most meaningful and what's most likely to impact their health and their life, at that visit? So I actually have not found that I think this can be done well in a 20-minute visit.
I think so too. When I present this to most physicians, particularly younger ones, their first question is, "What are we going to do about the quality metrics?" How do you feel about that?
So I think that I don't think that those are I don't think that those I wouldn't think about those as two different things, as like we're going to do gold corrected care and then we're also going to do quality care. I think they're much more interconnected, right? So I think if, for example, if you're talking about colon cancer screening, understanding why someone is or isn't invested in colon cancer screening helps you have a discussion about that, right? It may actually help you meet quality metrics if people are more invested and engaged in those activities that are going to benefit their health, and why. Um, and then, I had another thought, but I kind of lost it. But I think that's the primary thing is I think that they're complementary and I think one actually helps the other. I don't think that they're separate things.
I agree. What I usually tell people is that I don't know what would happen to your quality metrics, but they could improve just because even though some metrics wouldn't apply to some people, but when they do apply, people are more likely to adhere if they know why they're doing it.
I remember my other thought. I also think maybe we should be measuring whether we're doing this. Maybe part of quality of care is actually understanding what's important to people.
I totally agree with that, and I know you're working on that with the Joint Commission on quality assurance. Are you still doing that work?
I have some connection with NCQA. I had the pleasure of working with them on several projects around developing quality measures for goal setting in clinical care and measuring whether care is helping people meet the goals that are important to them. And so hopefully we'll have some opportunities to do some more grant work with them going forward.
That'll be great. Thank you very much. I really appreciate your time today. I know you're incredibly busy, and we've had that discussion.
Well,
Um,
this is a conversation near and dear to my heart. I think it's really important. It brings me joy to talk about. So thank you for the opportunity.
okay, bye.
Bye.